very eminent speaker, Dr. Nitin Sinha, who is Professor, Department of Medicine at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Armel Hospital. And he is also the sub-dean out there. And he is a very sought after and a knowledgeable teacher. And it is our privilege that we have him today to address what is called and commonly seen as nephritic syndromes. So, Dr. Nitin Sinha, I will request you to please start the deliberations. People are joining, and I think they will keep on joining. Dr. Nitin, please.
Yeah, thank you, sir. Thank you, sir, for your kind words. And I really thank you and the Indian College of Physicians for giving me this opportunity. And today, the topic of discussion is nephritic syndromes. So, as the name suggests, that nephritic syndrome, so it is something to deal with kidney and the various disorders which affect the kidney, which lead to a particular kind of a symptomatology. That is why all these diseases they produces almost similar kind of presentation. So they are grouped into one common umbrella, which is called as nephritic syndromes. So in today's deliberation, in the next 35-40 minutes, we will be discussing what is nephritic syndrome, what are the different diseases which are coming under this umbrella of this the term called as nephritic syndrome. We'll be discussing some of the very important and common ones in little bit of detail. How do they present? How are they managed? And what is their prognosis? So I think this is how we will start. So at the very outset, now what is a nephritic syndrome? It is basically an inflammatory condition of the kidney where the inflammation can occur to the glomerulus or the vessels which are there in the kidney and to the tubular interstitium region. So anything which is leading to inflammation there can present as nephritic syndrome. Any disease which is causing that can present as nephritic syndrome. It can be an acute presentation of a disease. It can be a subacute, which is occurring over days to weeks, or it can even be a chronic presentation, which is occurring over a span of few months. Now, the most important part of nephritic syndrome is given in the last point of this slide, which is that it classically presents that whatever the disease is, but most of them will have this common feature is that they present with hematuria. Now, this hematuria can be microscopic or it can be macroscopic. The urine can be cola colored, which means that the RBCs which are coming into the from the glomerulus into the urine, they get broken, they get lysed, and the hemoglobin is there in the urine, which in acidic urine tends to turn black or cola colored. Then comes the third part, which is the hypertension. Because of the RBCs coming in the urine and the damage to the glomerulus and the basement membrane because of different reasons, the RBCs enter into the urine and they form casts, which are called as the red blood cell casts, which are seen in the urine examination. As the name suggests, inflammation. So there is pyuria, which means that there are a lot of inflammatory cells in the urine, as well as if we do a biopsy, we find a lot of inflammatory cells, especially the polymorphonuclear leukocytes. And there is mild to moderate proteinuria. When I say this mild to moderate proteinuria, it means that it is not a nephrotic range proteinuria, which is 3.5 gram per day. But having said that, in certain diseases, which we will see in the next few slides, the disorder can or the disease can even manifest as nephrotic range proteinuria. So this is in general about what is a nephritic syndrome. Now, this is what the slide shows is a dysmorphic RBC. And on the right hand side, you can see what is the RBC cast. This is how they look in the urine examination or the urine routine examination, which we send. We normally, when we are suspecting a nephritic syndrome, we often ask the laboratory to do a dysmorphic RBC examination, RBC cast, and we sometimes even write, look for active sediments. So these are the active sediments which we tend to find. So this is what is the microscopic picture of dysmorphic RBCs and RBC cast. Coming to the disorders. Now, there are many disorders which are there. Now, if we will discuss them one by one. Broadly speaking, before I start discussing them, they either are complement immune complex mediated disorders or they are non-immune complex mediated disorders. So we'll first try and discuss those which are immune complex mediated disorders which lead to nephritic range or nephritic symptoms. So one of the first common diseases is post-infectious glomerulonephritis, which we commonly write as PIGN. Now, in this, the glomerulus is inflamed. It is an acute condition. It is an acute to subacute condition. It occurs more commonly in children in developing countries, but in developed countries, it is seen more commonly in the elderly. Males are affected more than females. Important point is that this disorder occurs within 10 days to 3 weeks of infection with nephrogenic strain, which are called as the M type of group A streptococcus, leading to pharyngitis. So whenever there is a group A streptococcus of a streptococcus which is a nephrogenic strain, M type, and it is causing pharyngitis, PIGN can occur within 10 days to 3 weeks after the infection. As we all know, streptococcus can cause skin infection, which is popularly called as impetigo. So they can occur even 2 to 6 weeks after an impetigo. Now, the antigen which has been identified of streptococcus, which causes this condition, are the streptococcal pyrogenic exotoxin B, which is called as SPEB, and another antigen which has been identified is the nephritis associated plasmin receptor. We popularly write it as NAPLR. They are the ones which trigger an immune reaction, which is mediated by complement, and finally this disorder occurs, and the glomerulus is involved. So this is in short the pathophysiology of PIGN. Now, presenting features, as I told you, it mainly occurs at an acute onset symptom. Remember, in the first slide, I told you some disorders will present as acute, some as subacute, and some as chronic. So this is an acute onset condition where there are classical symptoms which I have already mentioned in the first part, but oliguria can also occur. So 20% of adults can have nephrotic range proteinuria, and oliguria, that is decreased urine output, can also occur along with the nephritic symptoms and signs which I had already discussed in the first slide. Some of the individuals can have systemic symptoms in the form of headache, malaise, anorexia, and flank pain because of the renal capsule swelling. So all these are the presenting features and investigations. As we have already told, RBC cast, dysmorphic RBCs, hypertension, cola colored urine. So all these can occur. Apart from them, low C3, that is low complement level C3, positive rheumatoid factor, circulating immune complexes can be detected. I have written the prevalence or the occurrence of all of them in percentages in front of each of them. ASLO titers can be risen in 30% more than 200. However, nowadays newer antibodies in the form of positive anti-DNA, which is seen in around 70%, and anti-hyaluronidase antibodies seen in 40% can also be there. Streptococcus positive culture can be there in 10 to 70% when the disease is there. Now remember, and in the just previous slide, I told that this occurs after the infection. So normally what happens is by the time the kidney is getting involved, the active infection is gone. So the streptococcus might not be culturable. But in certain studies, it has been found that even when the kidney involvement is there, the culture can be there positive in 10 to 70%. In most of the time, the diagnosis is very straightforward. In the form of skin involvement was there, pharyngitis was there. There is a time lag of around 10 days to 3 weeks, and finally, this renal disorder is occurring. So, kidney biopsy is usually not required in PIGN. This is against as other diseases, which we'll discuss in the later, where kidney biopsy is a must for diagnosis as well as for treatment. But here it is not that required. So if there is a biopsy required, maybe there is some dilemma. And if we do a biopsy, if there is a biopsy is done, then this is what is the picture. This I have taken from Harrison's only. This is the subepithelial deposit, which we call as the hump. And these are the subendothelial deposits, which are there within the endothelium of the glomerulus. And this is the mesangium. So there are mesangial deposits. These are immune complex deposits, which we are detecting on electron microscopy. So this is what is the classical picture of PIGN kidney biopsy. So how do we treat? Once we have suspected, we have to now treat the patient. So we have to control the antecedent symptoms which are occurring, hypertension. We have to give them diuretics to treat edema, dialysis only if there is requirement, strict condition maintained, which are required for, for the dialysis. Antibiotics, if there is an ongoing streptococcal infection. Now there is an entity which I have not mentioned here, which is called as synpharyngitic glomerulonephritis, where it means that the pharyngitis is occurring simultaneously with the nephritic syndrome. It is a very rare entity, but it does happen. So in those situations where you are getting this kind of a picture, antibiotics are used. Otherwise, if there is no active infection going on, then there is no role of an antibiotic. Unless and until there are some superadded infections there or here and a patient is in ward or something, that is a different issue. But per se for the disease, no antibiotic is required if there is no active infection. And akin to like against what is seen in lupus and all, which we will discuss later, there is no role of any immunosuppressive therapy here. So what is the prognosis? Once we are dealing with the symptoms and treatment, the death part or the mortality is very rare in children, but is very common in elderly because of the renal involvement. In children, the disease occurs, it has a very good prognosis, it tends to resolve in few weeks, but the progression to ESRD is very uncommon in children. However, in elderly, death to hai, that is there and there, but there is high incidence of developing, end stage renal disease also. Okay, so this is what is the PIGN in brief for all of you. Coming to the next disease, which we will discuss, which is, I think, more common, more of us have seen it, we encounter it more commonly in our practice, is lupus nephritis. It is again an immune complex mediated disorder. Now, we all know what is SLE, systemic lupus erythematosus, and it is a multi-system involvement disorder where multiple systems of the body are involved. From maybe patient can have malar rash, discoid rash, recurrent oral ulcers, anemia, immune-mediated anemia, thrombocytopenias, arthritis, pleural effusion. So there are n number of presentations, psychotic features, seizures. But one of the most dreaded complications or dreaded organ involvement is the kidney in systemic lupus erythematosus, which we call as the lupus nephritis, or popularly it is called as LN, lupus nephritis. So it is seen in 30% of patients of SLE at the time of SLE diagnosis. It is more common in blacks and Asians and Hispanics rather than whites and Americans. It is basically DNA and anti-DNA, they bind together, they activate the complement and they form the immune complex and damage the glomerulus. It is more commonly seen in females as compared to males. PIGN was more common in males as compared to females. Here, apart from the nephritic syndrome, renal failure can occur. It can occur very fast. The disease can be relentless. It can progress very fast. So that is why lupus nephritis is dreaded. Anti-dsDNA correlates very well with the disease. Complement level C3 is low. Sometimes C4 is also low in 70 to 90%. There is a classification of lupus nephritis based on renal biopsy. Here, the biopsy is a must, which is in contrast to what was there in PIGN, where biopsy was not at all required, or maybe it was required only if there was dilemma. But here, the biopsy is a must because we divide the patient lupus nephritis into 6 classes, and classes can only be made based on the biopsy findings. So I think this slide has all the 6 of them, names of all 6 of them, and on the rightmost column, what major pathological change we see in any all these classes is written. So I will just name the classes and then we'll proceed to the next slide. Class 1 is minimal mesangial, class 2 is mesangial proliferation, 3 is focal nephritis, 4 is diffuse nephritis, 5 is membranous nephritis, and 6 is sclerotic nephritis. So 6 is a stage where patient has already progressed into a chronic renal or end stage renal disease. So 6 is just like any other CKD. But for us, the major involvement is 1, 2, 3, 4, 5, and treatment mainly occurs for 3, 4, and 5. So we will discuss them in detail in the next few slides. So this is what if the patient is having class 1 and class 2 nephritis. Now, these guidelines I have taken from KDIGO, that is Kidney Disease International Kidney Disease Improving Global Outcomes 2024 guidelines, where they have defined the treatment for some of the conditions, some of the diseases which lead to nephritic syndrome, and lupus nephritis is one of them. So these are the one of the latest guidelines which I am trying to present here. Now, if the patient is class 1 and class 2 based on renal biopsy as lupus nephritis, if there is low level proteinuria, immunosuppressive treatment is guided only if there are extra renal manifestation. Otherwise, for class 1, class 2, immunosuppressives are not given if this only kidney is involved. But however, if other organs or other systems are involved, then you take a call based on them, not based on kidney. However, if in class 1 and class 2, I told you in the very beginning of my presentation that sometimes they can present as nephrotic range proteinuria. So now if in class 1 and class 2, if there is a nephrotic range proteinuria more than 3.5 gram per day or more than 300 milligram per gram of albumin to creatinine ratio, which are different things for nephrotic syndrome definition, then you have to evaluate the patient on electron microscopy for lupus podocytopathy, and you have to treat this patient as you will treat a minimal chain disease in nephrotic syndrome. Nephrotic syndrome is a different, I think, topic which will be dealt, I think, next week, if I'm not wrong. There they will tell you how to treat minimal chain disease. But remember, class 1, class 2 nephritis, if having nephrotic range proteinuria, is treated as minimal chain disease of nephrotic syndrome. So here Once you treat, then you should consider maintenance combination therapy with once the patient is into remission, then you treat them with low dose glucocorticoid and some immunosuppressive agent to maintain remission. This is class 1 and class 2 lupus nephritis for all of you. Coming to the more important ones, that is class 3 and class 4. Now, these are the ones which are actually problematic for all of us, and you will find that these are the ones which offer us challenges also. So, what are the treatment guidelines for that? We have, if there is a class 3, class 4 lupus nephritis active, then please treat them with glucocorticoid. That is, they are active. That disease is presenting the here and now. So it is glucocorticoid where methylprednisolone, prednisolone, both can be given. I think everything is mentioned in the box. I will not read everything. I'm just going to tell you what is the crux points of all of these. So glucocorticoid, whether it is methylprednisolone given as a pulse therapy for 3 days, or maybe it is prednisolone given in dose of 0.3, 0.4 to 1 milligram per kilogram per day, not to exceed 80 milligram per day. You have to taper them and put them on a maintenance dose at the lowest possible steroid dose to prevent side effects of the steroids. Secondly, apart from giving steroids, we have to give an immunosuppressive agent. Now, calcineurin inhibitors, MPAA is mycophenolate mofetil. So either we give calcineurin inhibitors like tacrolimus, cyclosporin, or either we give them with mycophenolate mofetil, the combination of both, or either we can put them just on mycophenolate mofetil. Cyclophosphamide can be given along with steroid. This is another agent there. Cyclophosphamide can be given in IV form as well as oral form. However, oral form is preferred because of better patient compliance. However, if somebody is unable to tolerate the oral dose, then only IV cyclophosphamide is given. Both IV and oral cyclophosphamide are equally effective. Mycophenolate mofetil, cyclophosphamide, and other agent like CNI, they are all almost equally effective. So we give treatment based on the availability of the drugs, the patient tolerability profile. Now, cyclophosphamide, if somebody is trying to, is sexually active, wants to have babies, or maybe reproductively active, so they will not be given cyclophosphamide. Here, the agent of choice will be mycophenolic mofetil. That will be the agent of choice. So that is how we decide based upon the patient preference, based upon the patient condition. So we have a spectrum of drugs available. So we have to choose based upon the patient profile and the condition of the patient, and how the one drug is being tolerated by the patient vis-a-vis the other. Another newer drug is belimumab, which is given along with steroids and mycophenolate mofetil and reduced dose of cyclophosphamide. So this active phase, this initial treatment lasts for 2 to 6 months, which is called as the induction phase or the active phase of treatment of class 3, class 4 lupus nephritis. Now, after the active phase is over and the patient goes into remission, then we put them on a maintenance phase. Now, what is maintenance phase? Maintenance phase, you will listen this word in future, in the further diseases also. So it is better to explain here that maintenance dose means the steroids in the minimum possible dose, along with some immunosuppressant, which acts as a steroid sparing agent. So this is what is maintenance phase in most of the disorders, which we will discuss here as well as in the future slides. So now in lupus nephritis, class 3, class 4, prednisolone to less than 5 milligram per day as far as possible, along with mycophenolic mofetil, which is given the dose of 1 to 2 gram per day. So that is how it is given, which is maintenance dose. Patients who received, there are different categories of patient. I think you can all read. The drugs which are available are azathioprine, even calcineurin inhibitor like tacrolimus, mesoribine, cyclosporin. They are all available, which we can give as maintenance phase along with low dose of steroids. The next question comes is to how long to continue the maintenance phase. Whether we can continue 6 months, so we have already given the active phase. Now, to when do we continue maintenance phase? Is it lifelong? No, it is not lifelong. Here it is in most of the trials, in most of the literature, it is written 2 to 3 years. So I think we can give it based on patient monitoring and everything, give it for 2 years, and then finally we can decide as to when to withdraw the treatment based upon the patient condition. So that is how the treatment is given. There are certain response rates. Okay. So this is what is the kit. We'll go to class 5. Now, class 5, again, I told you 3, 4, and 5. They are the one which require treatment. This algorithm is almost self-explanatory, where if there is low level proteinuria, we have to monitor proteinuria. Class 5 lupus is very time associated with renal vein thrombosis. and dyslipidemia and edema. So it is the class 5 which is more notorious to have renal vein thrombosis rather than class 3 and class 4. And here we have to control blood pressure by renin-angiotensin, which reduces proteinuria also and controls the blood pressure. Immunosuppressive treatment is guided by extrarenal manifestations. If there is low level proteinuria, it is just like class 1 and class 2, where if the extrarenal manifestations are there, if they are meriting immunosuppressive, then give, but not for the kidney. And hydroxychloroquine can be used. Similarly, for nephrotic range proteinuria, immunosuppressives along with renin-angiotensin system and hydroxychloroquine, they are the ones which are given. So this is how we proceed for class 5, class 3, class 4. This is what is the current definition regarding response. Now, how to judge the response? So one is complete response, one is primary renal response, one is partial response, and one is no response. So there are certain set criteria for that. I'm not going to read all of them. If somebody wants to take a snap or maybe a picture of this or a screenshot, you are free to take. But these are all very simply written and very self-explanatory. So that when do we say it is a complete response and everything? So this is how we go ahead. Coming to the third disorder or the third third condition which leads to nephritic syndrome or a component of nephritic syndrome is subacute bacterial endocarditis. Here it is seen more commonly in patients with subacute bacterial endocarditis who are untreated. That is, they have bacterial endocarditis but have not received treatment, or if they have culture which are repeatedly coming negative or have right-sided endocarditis. They are the ones who are more likely to develop renal involvement. Now, glomerular involvement in such cases is subacute. It is not acute it is not seen with acute endocarditis because immune complex mediated injury takes around 10 to 14 days to develop. Kidneys have subcapsular hemorrhage, which is called flea-bitten kidney or gross. Just a second. Sorry for this mild interruption. So the kidneys, when we see them grossly, they have subcapsular hemorrhages, and we popularly used to call them as flea-bitten kidney. In our time, there used to be an MCQ on this. Where do you see flea-bitten kidney? So this is what is the condition. It is called subacute bacterial endocarditis. Patient present with classical nephritic features, and sometimes they present as rapidly progressive glomerulonephritis. I will just mention what is RPGN here. RPGN is nothing but an it is an acute condition of the kidney where there is rapid deterioration of the kidney function within a span of 3 months. And the classical presentation on biopsy of the kidney is crescents. Now, the crescents are present, which are actually the epithelial as well as inflammatory cells, which are encompassing around the glomerular vessels. So, when we see those crescents and there is an acute involvement, we call them as RPGN. So, most of these syndromes, they can present as RPGN. Whether it is lupus nephritis, whether it is PIGN, whether it is subacute bacterial endocarditis, they can all present as RPGN. So RPGN is a different way of defining things. So they can all present as RPGN. Embolic infarcts and septic infarcts can also be there because there is an infective foci within the heart. So kidney can be involved in different ways, in the immune complex way, by direct infarcts, by septic infarcts. So there can be involvement of kidney in different ways in subacute bacterial endocarditis. Investigation normally reveal normocytic normochromic anemia, elevated ESR, decreased complement levels. Some patient can have ANCA positive, can have type 3 cryoglobulin positive. Treatment mainly, and I think it is easier to suspect when we have a patient of heart disease who is having fever, long-standing fever, 2 to 3 weeks, and other symptoms of endocarditis, then we can suspect. And if they have kidney involvement, do consider them as having renal involvement. If there is some deranged kidney function you find in a patient of bacterial endocarditis, then it is mainly supportive, and the main treatment is directed against the endocarditis with antibiotics. And progression to ESRD is rare. It is one of the conditions which has a very good prognosis. If we treat infective endocarditis correctly and well, then probably this disorder also gets corrected very well. Now, coming to another entity, here it is called as anti-glomerular basement membrane disease, and it has another, another brother in the form of good pasture syndrome. Now, here till the time we have discussed the first three disorders, they are all immune complex mediated. Now, here it is different. Here it's an antibody mediated disorder. Here the autoantibodies are present against the glomerular basement membrane. Now, here the target epitope is the quaternary structure of alpha 3 NC1 domain of collagen 4. Now, these quaternary structures are usually hidden. They are not exposed to the body T and B cells. However, because of some perturbation in this disorder, this quaternary structure of alpha 345 NC1, it becomes exposed to the T cells. So here the T cells, then they stimulate the B cells, and finally the antibody response is there, which leads to damage to the glomerular basement membrane. So what is the presentation like? Apart from the nephritic syndrome, in good pasture syndrome, the involvement of the lungs is also seen in the form of breathlessness and hemoptysis. Good pasture syndrome presents as bimodal peak. It can occur in 20s, but mostly in men if younger. And in older population, it can affect both the men and women in their 60s and 70s. Lung involvement is more commonly seen in younger patients. Smoking aggravates the lung pathology. So, good pasture syndrome has involvement of lungs as well as the kidneys simultaneously. Renal biopsy shows focal and segmental necrosis, crescents in Bowman space, interstitial nephritis with fibrosis. Anti-GBM antibody along with complement are identified as linear immunofluorescent deposits. Serum can have anti-GBM antibody positive. Those who are more than 50% crescents, they tend to have worse prognosis. Serum creatinine, if at presentation more than 6, they tend to have worse prognosis. If they already have an oliguria and there is a need for dialysis, these patients tend to have worse prognosis. Now, how to treat good pasture? One is suspicion based on lung involvement, patient coming to you with saying, Doctor Saab, he is hypertension, he's having deranged renal function, he's having proteinuria, hematuria, he's having hemoptysis, he's in the 20s, he's a male, or if he's an elderly in the 60s and 70s, suspect glomerular basement membrane disorder or good pasture syndrome. Then the modalities which are available are oral prednisolone, immunosuppressive in the form of cyclophosphamide, and to remove antibody, that is plasmapheresis. These are the three modalities. So plasmapheresis plays a very important role in GBM disease because it tends to remove the antibodies from the body. So this was not a component of treatment in the previous three disorders because they were immune complex mediated disorder where the complex is already deposited on the kidneys. Here there are active antibodies which are roaming around in the blood. So that is why plasmapheresis becomes an important modality of treatment here. With this, we move to the fifth disorder, which I think everybody of us must have seen one patient or the other or must have heard. There are a lot of questions asked from this topic in the MCQs, in the entrance exams, in MBBS, even in NEET exams also for the super specialty is IgA nephropathy. A disorder which is not fully understood till date. It is not fully understood till date. But we see a lot of patients, like I have seen at least 4 to 5 patients of IgA nephropathy over the last 7 to 10 years in my stint in RML hospital. Now, it is more commonly seen in males, and the peak incidence occurs in the second and third decade of life. It is more prevalent in Asia and South Europe as compared to North America and the Scandinavian countries. Certain countries like certain parts of North Italy and in Eastern Kentucky in US, it has been found to be having familial inheritance also. The basic abnormalities in the O glycosylation in the hinge region of polymeric IgA1 gene. Now, how does it present? It presents with episodic gross hematuria occurring just after or along with an upper respiratory tract infection. So patient will present with some upper respiratory tract infection and they will have gross hematuria. They will give you a history also that doctor, this used to occur to me previously also. I used to have some bad throat, maybe cold, and maybe there was some nasal discharge or something, sneezing, and I don't know why there was blood in the urine. So just whenever there is such sort of a history, immediately the bell should ring in your mind that it could be an IgA nephropathy. Certain patient will not present like this. They will just present with persistent asymptomatic microscopic hematuria. They will present with anemia. So their presentation of anemia, you will work them up, you will find, oh, there is a microscopic hematuria going on, and then you work them up and find that this patient has IgA nephropathy. So there are two different contrasting ways of presentation of this disorder. Patient can have mild proteinuria. Renal failure per se is very rare in this disorder. So this is what is the picture. Kidney biopsy shows typical mesangial IgA deposits. You can see the ones in purple in this diagram. These ones, or the dark blue, you can call them dark blue. These ones, these are the mesangial deposits. These are the mesangial cells, and these are the mesangial deposits which are there, which are of IgA. And even IgA serum levels can be raised in, but they are seen only in 20 to 50% of the patients. So if you're suspecting IgA nephropathy and the IgA levels are normal, please don't be disheartened. They can be normal in around 50 to 70% of the patients. IgA level things can also be there in the skin biopsies. Patient tend to have complete remission. As you can see in the history also, they will say that we have recurrent episodes. So one episode subsides, they are asymptomatic, they again develop some kind of an upper respiratory tract infection, they again become symptomatic. Even in those who have persistent microscopic hematuria, the renal function are preserved. So the kidney failure part per se is very rare in this disorder. In certain people, it is seen that the kidney failure occurs. So it is select in a very select group of patients. And who are those? Those who have hypertension, those who have proteinuria which does not subside once the episode subsides and continues for 6 months or more, those who have never had macroscopic hematuria, that if there is a macroscopic hematuria, they tend to have lesser chances of developing end-stage renal disease. Male gender and older age, they are the ones who are more likely to progress, but the progression is very slow. It occurs over 20 to 25 years. Treatment mainly is just symptomatic, where ACE inhibitors for those with proteinuria or declining renal function. If proteinuria persists, then steroids, immunosuppressive, and a new drug which is called as sparsentan may be tried. Sparsentan is a new drug which is an endothelin and angiotensin 2 blocker. It blocks both of them simultaneously. So this drug has been found to be very effective in IgA nephropathy. And I will just show you a picture where this is the one. So this is what is the algorithmic approach to a patient of IgA nephropathy. So you can see that if there is a BP management, maximum RAS blockade is there. If proteinuria persists for more than 6 months, despite lifestyle modification and BP control, if there is adequate response, then just continue it, and you can even add SGLT2 inhibitors. If EGFR is more than 20 and less than 90. However, if the response is not adequate despite 6 months of RAS blockade as well as lifestyle modification, then you have to consider them for steroids, immunosuppressives, and sparsentan. So this is how the treatment approach to an IgA nephropathy is there. This is as per the current KDIGO guidelines, KDIGO guidelines. Another disorder which we see is the C3 glomerulopathies. It is a very rare disorder where mainly the problem occurs with the C3. This comprises of two disorders. C3 glomerulopathies itself has two disorders. One is called as the dense deposit disease, triple D, which is also called as the type 2 MPGN. I will discuss MPGN in the next is the next disorder which I will discuss, and the last disorder which I discuss. MPGN is of three types: type 1, type 2, type 3. Type 2 MPGN is also called as dense deposit disease, which is nowadays grouped under C3 glomerulopathies. And another entity is C3 glomerulonephritis, which is called C3GN. So there are two diseases in this spectrum. Here the problem is in the complement factor H regulatory protein gene, which is called a CFHR gene. The triple D occurs in children and young adults. However, this complement C3 glomerulonephritis occurs in older age group by around 30 years of age. Dense deposit disease with proteinuria, which can lead to nephrotic proteinuria, can be there with or without hematuria, and hematuria can be microscopic or macroscopic. 50% of patients with triple D, they progress to ESRD. And regarding C3 glomerulonephritis, two-thirds tend to have hematuria at presentation, one-third have proteinuria. And the chances of progression to ESRD are lesser as compared to triple T. Treatment is mainly by ACE inhibitor, lipid lowering agents, and if there is no response, then an anti-C3 monoclonal antibody, which is called as eculizumab, is being used nowadays. However, having said all this, this particular group of disorder is still under a lot of research. The treatment guidelines, as you have seen for IgA nephropathy, lupus, PIGN, they are not that well defined in C3 glomerulopathies. So they are still a hot topic for research, and a lot of work is going on in this particular group of disorders. Maybe next coming year or so, we will have well established guidelines for managing this condition also. The last disorder which I will discuss in the nephritic syndrome is the membranoproliferative glomerulonephritis. It is an idiopathic disorder which is present in children and young adults. It is of three types. Type 2 is triple D, which I have discussed in the previous slide. So I will discuss type 1 and type 3. Type 1 MPGN is an immune complex mediated disorder like PIGN or like lupus nephritis. It is commonly associated with persistent Hep B, Hep C. Now here it is important. It can occur with antecedent other infections. So it can occur with Hep B, it can occur with hepatitis C, fungal infections, parasitic infections, lupus, SB. So it can occur with other disorders also. This is what is the beauty of this disorder. It is not an isolated disorder in itself, which is called primary MPGN. It can be secondary MPGN with other disorders. So the classical finding on kidney biopsy is a tram track appearance of some endothelial deposits around the vessels and around the endothelium. So they form a tram track. So that is why it is called as tram tracking. Again, a very good MCQ which used to come in our times. Where do you see tram tracking in kidney biopsy? It has low serum C3 seen in 50% of the patients. Another is type 3 MPGN, which is here in type 1, it was a diffuse kidney involvement. Here it becomes a focal proliferation. So it is not that kind of a diffuse involvement as is seen in type 1. 50% of patients who have MPGN have tend to develop 50% tend to develop this end stage renal disease within 20 years. Hypertension, nephrotic syndrome, and renal insufficiency, if it is present with MPGN, it indicates usually a poorer prognosis. Treatment mainly is by ACE inhibitors, steroids, and immunosuppressives. Treatment of antecedent infection also assumes important if they are fungal, Hep B, Hep C, which tend to have a supplementary effect to the treatment of the kidney disorder. ANCA-associated vasculitis, there are three group of disorders which we all know. I think everybody knows about them. One is granulomatosis with polyangiitis, microscopic polyangiitis, and Churg-Strauss syndrome, which is also called as the eosinophilic granulomatosis with polyangiitis, EGPA. They are all ANCA positive. That is this first slide which I am showing is the common features among all of them. They have ANCA positivity. Granulomatous polyangiitis is anti-proteinase 3 type ANCA. However, the remaining two have anti-myeloperoxidase type ANCA. They cause post-immune glomerulonephritis, which means that the immune complexes are less. In PIGN, in lupus, immune complexes were more. In type 1 MPGN, the immune complexes were creating the main havoc. But here the immune complexes are less. And the target involvement is the smaller vessels of and the glomerular capillaries. This is the target lesion here. Mortality is high if there is no treatment. These disorders can be relentless. They can proceed very fast, just like lupus nephritis. Induction therapy is given with steroids and with a new drug which is called as avacopan. It is a C5a complement blocker, and it has been given used in trials where it has been found to be very effective in producing induction in ANCA-associated vasculitis. And with induction therapy, just like in lupus, we were giving steroids with immunosuppressives. Here we are giving them steroids or avacopan with cyclophosphamide or rituximab. Plasmapheresis is also done in patients if they tend to develop rapidly progressive glomerulonephritis. That is, if they have lot of crescents in the biopsy, then we do plasmapheresis. Remission occurs in around 80 to 95% of the patients. Maintenance therapy after the induction phase is by low dose steroids and with immunosuppressive, just like we were doing in lupus. Now, here the granulomatous now we'll discuss three of them, brief part of each, how they are different in their presentation. Some things are common in them, which I have discussed in the first slide, and now what we are discussing is how they are different in their presentation. So granulomatosis with polyangiitis is mainly seen in patients who are exposed to silica dust and they have alpha 1 antitrypsin deficiency. It is seen more commonly in them. Here, sinus involvement, nose involvement, upper respiratory tract involvement is there in the form of fever. They can have purulent rhinorrhea, nasal ulcers, sinus pain, cough, hemoptysis, breathlessness, arthritis, arthralgia, hematuria, and subnephrotic range proteinuria. Renal injury can occur later. Chest X-ray has nodules and cavities. Microscopic polyangiitis differs from the granulomatosis one in just one thing, that they do not have involvement of lungs and sinuses. So it is pure kidney involvement in microscopic, but in granulomatosis, it is involvement of the upper respiratory tract as well as sometimes the lower respiratory tract. So this is what is the gross difference between the two. When we come to the Church-Strauss syndrome, it has peripheral eosinophilia, cutaneous purpuras. Patient can have asthma and allergic rhinitis. So if somebody is coming to you with asthma, allergic rhinitis, kidney involvement, please suspect, and peripheral eosinophilia, please suspect Church-Strauss syndrome in them. So finally, coming to the concluding slide, many diseases form the spectrum of nephritic syndrome. We have discussed many of them. Some are immune complex mediated, some are antibody mediated. So there is a whole spectrum of disorders. Some have different presentations. Some occur in different age groups. Some have involvement of lungs simultaneously with the kidneys. Some have involvement of other organs. Some are multi-system disorders like lupus nephritis. So kidney involvement can be there in all these disorders, in all these diseases, in the form of nephritic syndrome. It is very important that we have a strong index of suspicion. We suspect them early. We suspect them, treat them early with the proper as per the proper guidelines, so that we can prevent these patients from developing end stage renal disease or other complications of renal failure. With this, I thank you.
Well, thank you, Dr. Nitin, for an interesting presentation, and I am sure everybody would be wiser with the summary of this nephritic syndromes and overview that you have given. And it is a vast topic, but you have made it very simple and classified things. So there are a couple of questions. I think you can take a quick question. Why nephritic syndrome usually occurs in children while others are common in adults?
See, Dr. Neha, I think what you have put is there are certain disorders of nephritic syndrome which are common in children, like PIGN is more common in children. However, some are common in adolescents, some are common in the elderly. I think in my presentation, I told you that some of them can even come in the elderly age group. So I think it is just that it is the epidemiology. Maybe PIGN, early exposure to infection, the children are not immune, so they tend to develop this. That is why they probably are more symptomatic in the children. The next question you have put is silent presentation of nephritic syndrome. So one of them is IgA nephropathy. Okay, so this is something where they can have persistent microscopic hematuria. They can be there chronic patient where they don't manifest as acute condition, where they don't present with florid manifestations. They can be there. So it is there. Silent presentations can be there. Any other question?
Well, I think there are no more questions, Dr. Nitin. So I should thank you and the ICP once again for this session. And thank you, participants, for being there. And I am sure they will benefit with this great lecture of yours and look forward to the next presentation. Well, thank you, everybody. Thank you
Thank you, sir. Thank
and
you,
all
sir.
the best. Bye.
Thank you, sir. Thank you for inviting me.
We can
Thank you.
close the session. Yes, thank you.